This conference will now be recorded. This conference will now be recorded.
Good morning, everyone. I'm Dr. Bharath, Assistant Professor, Department of Orthopaedics. Today we are going to discuss about Pott spine. So, should I start the class or should I wait for some more time?
స్టార్ట్ చేసేయండి సార్ జాయిన్ అవుతున్నారు
Okay, yeah. So, Pott spine, it's also called as TB spine. 1 minute. So, TB spine, it is known after Sir Percival Pott, as you can see in the picture. It's called as Pott spine. It accounts for 50% of all skeletal TB. So regional distribution, when you come to the regional distribution, the most common involvement is dorsal, dorsolumbar and lumbar. So the most common location is dorsal, which comprises 42%, dorsolumbar is 12% and lumbar is 26%. And the reasons for predilection in the thoracolumbar region, it is because of large amounts of spongy tissues within the vertebral body and degree of weight bearing, which is comparatively more over the thoracic and lumbar vertebra, and the mobility is more at the thoracic spine and lumbar spine when compared to cervical and sacral. So it comprises of 80% of the total affection of spine, TB. So just a brief discussion on the anatomy of vertebra. As you can see, the first picture, this is the body of the vertebra, and from the body we can see the process which arises on pedicle, and the continuation of pedicle is a lamina. This is a lamina, and the processes which are the thing which is posterior is spinous process, and these are the transverse process. And you can see the facets. These are the facet joints. Okay, so on the lateral view you can see that the facet joints of the above vertebra articulate with the below vertebra. This is a facet joint, and the soft tissue which is present in between two vertebra, this is a disc. So posteriorly it is the spinous process and transverse process. So depending on the site of involvement within the vertebra, it is categorized into anterior part of the vertebra, central part of vertebra, and posterior part of vertebra, and paradiscal, which is the space adjacent to the intervertebral disc. So site of involvement within the vertebra, it could start in any part of the vertebra. 95% it is seen in anterior, and only 5% is seen in the posterior vertebra. Sorry. So this comprises only 5%, and the complete thing comprises of 95% of the involvement of TB. So anterior involvement includes central, intervertebral spaces, and anterior. Posterior, it is appendiceal, transverse process, and rarely the vertebral arch. So true tubercular, usually arthritis will not develop in any part of the spine, but it develops only in the atlantoaxial and the atlanto-occipital, which are the cervical vertebra. And coming to the types, metaphyseal or intervertebral space, it is the most common involvement. Okay, this part adjacent to the, it's called paradiscal, so it is adjacent to the disc. So 95% it is without any reason why this is predilected for most common involvement, but embryological development explains the reasons, which is lower half of the upper vertebra and the upper half of the lower vertebra, this part and this part, it is supplied by they develop from a common sclerotome. So there will be a single source of blood supply. As you can see, there is a vessel supplying the lower part of the upper vertebra and the upper part of the lower vertebra. So the most common predilection is this area, which is derived from a single sclerotome. And central type, it is C. This is the less common type. When TB occurs here, there will be a collapse of the vertebra, as you can see in this picture. So the vertebra gets collapsed. So it will be like a concertina collapse. and the anterior thing, you can see B. Okay, anterior surface of the vertebra. This is the anterior part and this is the posterior part. So anterior part is involved, which causes destruction of this part of the vertebra. So it results in a wedge-shaped collapse. So as you can see, there will be a wedge-shaped collapse in the vertebra. This vertebra is normal and the below vertebra is normal. But the middle vertebra which is affected, it becomes as a wedge shape due to the collapse of the anterior, and the posterior remains the same. So it will be like a triangle. This is a wedge. Okay. This gives anterior wedge compression of the vertebra. And coming to the sequence of pathology, usually the primary foci is seen in the lungs, lymph nodes, or abdomen, anywhere. So lungs is pulmonary, lymph nodes, and gastrointestinal TB. So from here, there will be basilemia, like replication of the bacteria. And from there, the basilemia, the bacteria develop and it reaches the spine to the Watson's venous plexus. As you can see in the picture, Watson's venous plexus is a intricate venous plexus which supply the complete spine. So sequence of pathological events, and for your information, Pott span can be given as an essay, or some parts of it can be given as a 4 marks or a 2 marks. So sequence of the pathological information as pathological events. Tuberculous endarteritis develops. It results in the marrow devitalization. That means it will destroy the marrow. So then there will be a follicle development, and the lamellae are destroyed due to the hyperemia, which causes osteoporosis, which is weakening of the bone. And due to the weakening of the bone, there will be a compression of the vertebra. So thoracic vertebra, as already discussed, there will be an anterior wedging. So this results in the deformity which is called kyphosis. Okay. In the lumbar and the cervical region, normally you will see lordosis. So the lordosis will get corrected, but it will not be much deformity. But in thoracic vertebra, there will be more prominent deformity, which is a kyphosis. So there are 2 types of vertebral reactions. You all know that TB heals with caseous necrosis, but in case of spine, the caseative reaction is rare. The exudative reaction is the most common. This causes severe osteoporosis and it spreads rapidly, which may result in the formation of a cold abscess. And the constitutional symptoms are more pronounced, which are fever, loss of weight, loss of appetite, and night cries. So cold abscess. First thing, why it is called a cold abscess? Okay, because there will not be any inflammation. So it's called cold, not because it is cold. And it results, here you can see it penetrates the epiphyseal cortex and involves the adjacent disc and the vertebra. So if one vertebra is involved, it crosses the disc and involves the upper vertebra or the lower vertebra. It may also spread beneath the anterior longitudinal ligament and it may reach the neighboring vertebra. So cold abscess, it can be formed anywhere and it can spread either anteriorly this way, or it can spread posteriorly, or it can spread laterally, or even down. Down means to the lower vertebra. So posterior, if it spreads, this is a spinal canal where you can see the spinal cord. So if it spreads posteriorly, it causes pressure on the cord. And it is most common in the thoracic region because of the small spinal canal. And the posterior longitudinal ligament, PLL, it limits the spread of sequestra and bone fragments into the joints. So the same thing, it may even penetrate anteriorly through the anterior longitudinal ligament, and usually it prefers the lines of least resistance. So like along the facial nerves, blood vessels, and nerves. And this may be given as a 2 marks question for you, cold abscess. Cold abscess consists of serum, WBC, caseous material, granulation tissue, and tubercular bacilli. Okay. Again, I repeat it. Serum, WBC, caseous material, granulation tissue, and tubercular bacilli. So coming to the clinical features, TB spine, it's usually insidious in onset and it may present acutely. The constitutional symptoms already discussed. There will be a spine involvement, weakness, anorexia, night sweats, and cries. It's because of the why the pain is more during the night? It's because of lack of the muscle spasm during the night. Muscle gets relaxed, due to which the pain occurs. So evening or afternoon rise of temperature, loss of weight and loss of appetite. Clinical features, they complain usually of back pain, and depending on the involvement of the vertebra, if cervical vertebra is involved, the pain radiates to the arm. If dorsal roots are involved, the pain radiates to the shoulder girdle and even to the scapular region. And lumbar, it radiates to the groin. And sacral, the patient complains of sciatica, like radiating pain downward. So the most common complaint and the earliest complaint is the back stiffness. The patient complains like I'm not unable to bend and pick up objects from the ground. And he clearly describes that he has a pain more during the night, which is called a night cry. So coin test, if we place a coin over the floor and ask him to pick it up, he will not be able to pick it up because of the pain. Okay, so stiffness, weakness and awkwardness of the lower extremities, and it may even progress to paraplegia. So very protective attitude and very cautious and careful gait. This is called an alderman's gait. And the muscle spasm, which straightens out the spine. The spine will be straight because of the muscle spasm, and there will be tenderness over the spinous process. And if we try to hold the vertebra and just move it, it will cause a lot of pain to the patient. And the back movements are decreased in all directions, especially forward flexion, which is the coin test. So physical findings, you can see there is a wasting of the paraspinal muscles, all back muscles. And cold abscess, you can even see the swelling when examined. So physical findings, here you can see the child is having a deformity of spine, which is kyphoscoliosis, and even here the chest is protruded. It's because of the kyphosis. Okay. So the most common deformity seen in TB is kyphosis, not scoliosis, but kyphoscoliosis may be seen. So general examination, signs of anemia will be seen, and you need to look for the involvement of lungs and lymph nodes. So typical attitudes in skeletal TB. Just remember at least the lower thoracic and the upper lumbar. Lower thoracic, it's called alderman's gait, and the upper lumbar, it's like a prominent abdomen. And this is a cold abscess. Okay, this doesn't look cold, but it is cold because we don't see much inflammation. So it may spread behind if it is from cervical, it may spread behind the prevertebral fascia. This is the sternocleidomastoid muscle. It's situated posterior to the sternocleidomastoid. Okay, so the posterior edge of sternocleidomastoid and the retropharyngeal space, and even it may gravitate down to the trachea, esophagus and tracheal cavity, which is the mediastinum. Okay, it may progress down, and sometimes it may develop from into the pleural cavity, and from it seeps backward through the lateral aortic ligament, quadratus lumborum, and even it may seep down to the kidneys. It may remain behind the kidneys also, or sometimes it passes forward and it presents on the anterior abdominal wall. This is everything from the cervical region. From cervical region, it may spread downwards till here. So from the thoracic region, usually thoracic region, it spreads posteriorly, which may cause compression of the spinal cord and may cause paraplegia, and it may spread laterally towards the extrapleural space, causing effusion, and it may penetrate the ALL, anterior longitudinal ligament, which is present anteriorly, and it may enter the mediastinum. Okay, sometimes it may it may remain prevertebral, or it may spread through the medial aortic ligament, enters the psoas sheath, lesser trochanter. Lesser trochanter is a part of femur, so it may extend even to the thigh. Okay, this is the yellow thing you are seeing. It's a psoas abscess. Okay, psoas abscess will be this much big. So it may spread along the psoas sheath and the femoral triangles into the femoral vessels into the femoral triangle, and even it may pass backward into the gluteal region through the gluteal vessels. As you can see, it may spread retropharyngally, even in the neck, axilla, beside the vertebra, paravertebral, and even it may be present in the lumbar petit triangle, lumbar triangle of petit, which is bordered by latissimus dorsi, external oblique, and the iliac crest. Okay, this is the lumbar triangle of petit. Okay, you can see a swelling over here. And cold abscess is called cold because it's not associated with features like redness and heat, as in pyogenic abscess. Pyogenic abscess, you feel the four salient features of inflammation, but in a cold abscess, you won't find anything. Okay, so again, a quick revision. Kyphosis is seen in 95%, the most common thing. It may be associated with scoliosis also. Kyphoscoliosis may be seen, or even only scoliosis may also be seen. There can be lordosis, boarding, and paravertebral thickening. Okay. So what are the other features? Muscle spasm, wasting of all muscles, spastic paraplegia, cold abscess in 20% of the patients, and complications of the skeletal TB. So laboratory investigations, what do you do? The simple things: complete blood picture, hemoglobin, and there will be a lymphocytosis, and there will be hypoproteinemia in TB. Usually there will be hypoproteinemia in TB, and ESR will be at least 40. Definitely it will be at 60 or 80. If you test for any patient, if the ESR is 60 to 80, you can suspect TB in 90% of the cases. So radiographs. What after the blood investigations, you send the patient to X-rays. X-rays, not X-rays, it's radiograph. So at least you can see there will be disc space narrowing, which is the space between the vertebra is narrowed, and sometimes there will be complete loss of disc space, and there will be an osteopenia. So here you can see the anterior compression of vertebra. This vertebra is normal, and even this vertebra is normal, but here there will be an anterior wedging of the vertebra, which is like the shape of a triangle. Okay, this causes kyphotic deformity. And already discussed, central vertebra collapse, it becomes a concertina, like it collapses in a uniform way. It will be a small rectangle type. So if it is involved in the posterior vertebra, there will be dissection in the posterior elements. And even you can see in late stages, you can see there will be a soft tissue calcification also. And here you can see the vertebra is being healed. Okay, two PG bits will be there. Usually the TB heals with fibrous ankylosis. Ankylosis is the fusion of the spine. Okay, so fibrous, usually the TB heals with fibrous ankylosis, except in spine, where it heals with bony ankylosis. But pyogenic, usually it heals with bony ankylosis, but in spine it heals with fibrous ankylosis. Just remember it again. It may be given as a bit for you, an easy bit, don't miss it. So in TB spine, it heals with bony ankylosis, and in other parts it heals with fibrous ankylosis. So paravertebral shadow, which is seen around the spine, it indicates a cold abscess, and in the cervical region it may be present in between the vertebral body and the pharynx. And if it is in the upper thoracic region, there will be a widened mediastinum. So here you can see a fusiform or a bird-like appearance. Okay, here also. And just remember this thing, aneurysmal phenomenon, where there will be an abscess which exerts pressure on the vertebra. Here you can see there is a sclerosis, and there is some amount of pressure on the vertebra which causes something compressing on the vertebra. This is called an aneurysmal phenomenon. Okay, scalloping effect. So CT scan, the next investigation of choice. This is to assess the degree of the neural compromise. And the next thing, CT scan again. And the next thing you take is an MRI. MRI is for the further delineation of the disease, and it helps in the estimating the amount of cord compression. Here you can see the cord is compressed completely. This is the thing which causes the paraplegia in a patient. So usually it eliminates the need for the biopsy. If you can see the findings in MRI, it is diagnostic of TB. Okay, here you can see the disc space involvement, and it is compressing on the vertebral cord. Okay. And bone scans, usually gallium scan can be used in disseminated TB, biopsy, and it is the 100% accurate test for definitive diagnosis. Okay, so diagnosis is dependent on the culture. You take a biopsy and send it for the histopathological examination and even for culture. As you all know, the medium used is Lowenstein-Jensen's medium, and recently you are using BACTEC. And ultrasound, it is to detect the size of cold abscess in the lumbar vertebral disease. So everything you need to write it in the diagnosis category. Diagnosis, you start with the blood investigations, radiographs, CT, MRI, biopsy, and now ultrasound. So this is what we call as a gene expert or CBNet. This is the thing we are using it now, even in government setup for detection of TB, which we can have it in 6 hours. Lowenstein-Jensen medium, the Mycobacterium tuberculosis, it takes about 3 weeks to grow. But in CBNet or gene expert, you can identify TB within 6 hours. So treatment, medico-legally, now there is a thing where you shouldn't start treatment unless the TB is confirmed. There is no thing like it's empirical treatment. It should be diagnosed and it should be treated. So definitely diagnosis is a must, and there is no role of long-term bed rest in the treatment of TB spine, which is previously prescribed. But now ambulatory chemotherapy. So ambulatory means the patient can walk, but he should receive chemotherapy. Usually 30% of the TB spine can be treated with chemotherapy. So indications of surgery, if there is an involvement of the spinal cord, or if there is a severe deformity, or if the chemotherapy is not limiting the disease, if there is a resistance to the chemotherapy, or if there is a recurrence of the disease, or after you start the chemotherapy, there is a cord compression, you need to go for surgery. And spinal instability, if there is an instability of the spine, you need to go for surgery. What are the surgical procedures? Simple thing is aspiration. You just aspirate it. You need not remember all these surgeries. It's for the PGs, but just remember aspiration, minimal debridement, radical debridement, and spinal fusion. Okay, spinal fusion can be done with anterior or posterior. Spinal fusion means you debride the total thing and fix it with a bone graft. So surgical procedures, aspiration. You can aspirate a psoas abscess this way. It can be done CT guided or ultrasound guided. So this is what I told, minimal debridement. You just remove the involved vertebra, this part of transverse process and the rib. This is called costo transversectomy. Costo is rib and transverse process is the transverse process of vertebra. You remove this part and enter the vertebral cavity or posterior elements, whatever it is, and you decompress it. So radical debridement, if the patient is associated with neurological complications, you need to do a radical debridement and a spinal fusion, which can be done anteriorly or posteriorly. I don't think you need to just mention the words anterior or posterior spinal fusion. And the complications: paraplegia, cold abscess, sinuses, secondary infection, amyloidosis. This may be given as a bit for you. One of the rare complications of TB, and fatality. It may result in the death. And this person is a great person who invented the middle path regime. He is Dr. Tuli. He has written a book on musculoskeletal TB, every TB in the body, for orthopedics. So treat the TB spine with the triple drug therapy without surgery. So in the middle path region, when you need to do surgery for the patient, if there is no response after 6 months, and if there is a recrudescence of the disease, and if the patient is having neurological complications. Okay. So coming to the questions you needed. So Pott spine can be given as an essay, or diagnosis of Pott spine can be given as a 4 marks. Cold abscess can be given as a 2 marks or a 4 marks. So for diagnosis, you need to tell this blood investigations, X-rays, CT, MRI, ultrasound, and at least you can write 1 or 2 findings in everything. And coming to the cold abscess, you need to tell the cold abscess from cervical, thoracic, and lumbar where it spreads. And if it is an essay, you just need to write it down as a like introduction, clinical features, pathology, diagnosis, treatment, surgery. Okay. So, any more doubts, or can I end the session? If someone can please respond so that I can end the class.
No doubt. No doubt, sir.
Okay. Okay. Thank you.